All right. Imagine trying to navigate a needle into a space literally the size of a grain of rice. You're completely blind, your only guide is the feeling in your fingertips, and the stakes? We're talking total pain relief on one hand versus potential paralysis or systemic toxicity on the other. Welcome to this explainer. Today, we're diving deep into the fascinating, high-stakes world of neuroaxial anesthesia. It's a field that demands absolute mastery of 3D anatomy, executed entirely by feel. So, let's break down the science and the techniques that make these procedures both incredibly safe and effective.
So, think about this for a second. What happens when we're faced with a major surgery, but we really want to avoid putting the patient under general anesthesia? This question is basically the heart of our whole exploration today. How do we provide the perfect, safe surgical conditions for the lower body or offer powerful pain relief during labor without knocking the patient completely out? The answer is neuroaxial anesthesia. It's all about targeting specific nerve roots in the spine, effectively blocking sensation while keeping the central nervous system out of the equation.
To get there, here's our game plan. We'll hit the basics, look at evaluating patient outcomes, dive deep into spinal anatomy, cover patient prep and positioning, and finally, we'll track the actual journey of the needle. Okay, let's kick things off with Section 1, the absolute basics of neuroaxial anesthesia. We're talking about the two heavyweight techniques every single anesthesiologist has to master. First up, subarachnoid or spinal anesthesia. This is a single shot directly into the cerebral spinal fluid. Boom! You get a rapid, incredibly dense block. The catch? It's got a finite duration, usually maxing out around 2 to 3 hours. Epidural anesthesia, on the other hand, needs a larger dose and takes a bit longer to set up, but its absolute superpower is flexibility. By sliding a catheter into the epidural space, you can continuously redose the med, seamlessly matching the length of the surgery or giving extended pain relief for labor. Moving right along to Section 2, let's talk about evaluating patient outcomes. Now, this is where the data gets really interesting. For years, the debate has raged. Is general or neuraxial anesthesia inherently safer? Early meta-analyses pointed to neuraxial as the winner, showing reduced 30-day mortality and less post-operative pneumonia, especially in major joint surgeries. But, science never stops checking itself. Huge, massive, modern databases tracking tens of thousands of patients have actually shown no distinct mortality difference between the two. Even post-op delirium looks similar across both. The big takeaway here? The data is constantly evolving. You have to stay neutral and evaluate based on the specific patient in front of you.
Section 3. Navigating spinal anatomy. Honestly, consider this the ultimate exercise in applied anatomy.
We're starting big, at the macroscopic level, with the vertebrae. You know those bumps you can feel straight down a patient's back? Those are the spinous processes, and they are your primary surface landmarks. Moving deeper, we hit the lamina and the pedicles. These essentially fuse together to form this protective bony armor around the spinal canal. When you're doing these blocks, knowing the exact angle and depth of these bony projections is absolutely critical. Your needle has to thread the needle, so to speak, through some very tiny windows. Pushing deeper, we run into a major soft tissue landmark, the ligamentum flavum, also known as the yellow ligament. It's this dense layer packed with elastin. But check this out. Notice the gap right in the midline? In about 10% of patients, the left and right halves just naturally fail to fuse completely. This little anatomical quirk is exactly why you can't rely purely on textbooks. You literally have to read the tissues through your hands. Listen to this quote, because building this sensory narrative is everything. You're feeling for the snap of the supraspinous ligament. Then you hit the mushy resistance of the intraspinous ligament. And finally, you hit the dense, gritty texture of the ligamentum flavum. Since you can't see the tip of your needle, knowing exactly where you are based solely on these distinct textures, that is the absolute hallmark of an expert. Okay, so here is a real game changer about your destination. Historically, people pictured the epidural space as this uniform, continuous tube. But it's not. In reality, it is a series of discontinuous, fat-filled pockets alongside a bunch of epidural veins. It's a potential space. It only actually opens up when you inject liquid or air into it. This completely explains why a catheter can occasionally veer off course or hit a vein if you aren't perfectly aligned in the midline. Going even deeper, past that epidural space, we hit the meninges. These are your final microscopic guards protecting the delicate spinal cord and the CSF. We're dealing with 3 distinct layers here: the outer dura mater, the middle arachnoid mater, and the inner pia mater. But if we zoom in on this interface, there's a huge surprise. You'd think the thick, fibrous dura mater does all the heavy lifting, right? I mean, it's about 280 micrometers thick. Actually, scratch that.
It is the tightly packed cellular architecture of the arachnoid matter just beneath it that does the real work. The arachnoid is what truly stops drug movement and keeps that cerebral spinal fluid securely locked away in the subarachnoid space.
Which brings us to Section 4, patient preparation and positioning. Let's look at how all this theory translates to the real world. Look, things can go wrong. An unrecognized intrathecal injection, where a massive epidural dose accidentally hits the spinal fluid, or systemic toxicity from local anesthetics hitting the bloodstream, these are huge emergencies. So prep is absolutely non-negotiable. Before the patient even walks in, your cart needs to be stocked. We're talking bag valve masks, endotracheal tubes, and crucially, a 20% lipid emulsion. That lipid is your ultimate rescue mechanism for systemic toxicity.
With the safety net completely in place, it's all about positioning. Sitting up on the edge of the bed or lying curled on their side, the goal is exactly the same. The patient has to flex their lumbar spine. We tell them, arch your back like an angry cat or like a rainbow. It's a simple move, but it physically opens up those bony interspaces we mapped out earlier, giving your needle a clear shot.
Now, let's talk hardware. Check out the difference here. Thinner, pencil-point spinal needles actually separate the dural fibers instead of slicing them, which hugely drops the risk of a post-dural puncture headache. Compare that to the thicker epidural needles, which usually have a curved 2E tip. You need that larger diameter to actually feel your way through those dense ligaments, and that curved tip is what safely directs your flexible catheter right where you want it.
All right, final section, Section 5, the needle's journey. Let's put this all together and follow the physical path.
Doing a subarachnoid block is so incredibly tactile. First, you find the midline using the spinous processes. Pop the introducer needle through the skin, and then slowly advance your delicate spinal needle. Holding the hub with just your fingertips, you literally feel your way through the changing density of the ligaments millimeter by millimeter. Then, you feel it, that distinct pop as you pierce the dura. You pull the stylet, and seeing that clear CSF drip out, that's your absolute confirmation of success.
But hey, it doesn't always go perfectly, right? What if your needle strikes hard bone pretty deep in there? You haven't hit the spinous process. You've almost certainly hit the lamina. But this is good. It tells you exactly where you are in 3D space. You just pull back slightly, redirect a tiny bit cephalad, meaning toward the head, and gently walk off the bone, advancing until you slide right past the lamina into the target space.
On the flip side, finding the epidural space is totally different. You don't get that visual confirmation of spinal fluid. It's all about the genius loss of resistance technique. Once your needle tip is biting into that gritty ligamentum flavum, you attach a syringe of air or saline. You push on the plunger and slowly advance. You'll feel intense pushback, but the exact microsecond your needle clears the ligament and pops into the epidural space, that resistance completely and incredibly satisfyingly just vanishes.
So, as we wrap up this explainer, I want you to think about this. You are operating entirely by feel. You're translating a deep mental map of anatomy into tiny, calculated micro-adjustments at the end of a needle. Mastering this blind, 3D anatomical puzzle, does it just make you a good practitioner, or is this what elevates neuraxial anesthesia into an absolute art form? Thanks for joining me today, and keep questioning what lies beneath the surface.